Hey, what's up, you guys? My name's John Thompson. I'm a critical care paramedic at ACT Ambulance in Brookfield, Illinois, and today we're going to talk about necrotizing fasciitis. Necrotizing fasciitis is an aggressive infection that results in the destruction of muscle fascia and the enveloping subcutaneous fat. It's a swift-spreading bacterial infection that can result in mortality or amputation if not recognized quickly and treated appropriately. Its origin is often a small cut or abrasion in the skin that gives bacteria a route inside. This leads to a cascade of severe symptoms, including red, purplish skin at the infection site, intense pain, edema, nausea, vomiting, and fever. Nec fasc cases are categorized in two distinct groups, type 1 and type 2. Infections originating from multiple microbes are type 1, and type 2 infections have just a single critter responsible. The majority of cases fall under type 1, typically affecting individuals with risk factors like immunosuppression, diabetes, chronic renal failure, malignancies, alcoholism, drug abuse or smoking, and chronic systemic diseases. These cases include Fournier's gangrene, involving the perineum and often scrotum, and Ludwig's angina, a sublingual necrotizing infection. Type 2 is a less common monomicrobial variant. It occurs in otherwise healthy patients, often with a history of minor trauma. The usual pathogens in type 2 infections are Streptococcus pyogenes and Staphylococcus aureus, with an escalating number of cases associated with MRSA. Despite rapid and high-quality treatment, mortality still hovers around 11 to 22%. Even in the hospital setting, diagnosis can be difficult, given that the initial presentation often resembles a typical dermatitis. Lab tests and medical imaging can suggest necrotizing fasciitis, but not rule it out. The gold standard for confirmation is surgical exploration in cases of high suspicion. When in doubt, a small incision can be made into the affected tissue. I know we're not doing this in the back of the ambulance, but we're going to go there today just for fun. If a finger easily separates the tissue along the fascial plane, the diagnosis is confirmed and an extensive debridement should be performed. But if you're not willing to shove your finger in a festering wound, bedside ultrasound may be a valuable tool to support a suspected diagnosis. This non-invasive approach aids providers in visualizing potential fascial plane separation, offering additional insight. The mnemonic STAFF is used for assessment, subcutaneous thickening, air, and fascial fluid. Realistically, in the pre-hospital setting, what we're looking for is red, purplish skin with large fluid-filled blisters, cellulitis, dysesthesia or paresthesia, crepitus or sub-Q emphysema, tenderness to palpation beyond the erythematous border, and a foul smell. The cornerstone of treatment for necrotizing fasciitis lies in the early initiation of broad-spectrum antibiotics, covering gram-negative, gram-positive, and anaerobic bacteria. Intravenous fluids, either lactated ringers or plasmolite A, are crucial. If a septic component is suspected, early initiation of fluid resuscitation and vasopressors is important to ensure organ perfusion.